So here we're going to talk about the third major way to create pain sensitivity, which is going to be by sensitization of the spinal central synapse. When we talk about sensitization, we have to go back to that lecture in neurophysiology where we talked about LTP, long-term potentiation, and how when we have a synapse, if we wanted to make that synaptic transmission stronger so that an action potential here released more neurotransmitter and had a bigger effect, and then created a much stronger signal going on, then we were going to have to make changes to that synapse. So we talked about different ways to do that, new channels, new receptors, and all of them had to do with increasing the volume of a signal. LTP is just that way to increase the volume. Whether that's good or whether it's bad depends on what synapse you're increasing. So these are some examples of different synapses that have synaptic sensitization, or LTP. You have it in your hippocampus. If you don't, then you can't put down new memories. So really important there. You have it in your prefrontal cortex. If you don't have synaptic sensitization, LTP there, then you'll never learn new skills. However, if you have it in your pain pathways, that's going to be a problem. So you can have that sensitization. Most commonly, we talk about it at that central spinal synapse, the main synapse transmitting that pain signal. So from the peripheral nerve to the ascending nerve. And in this case, you're strengthening or producing LTP across that synapse. And we can see that in neuropathic pain conditions that happens, and in inflammatory pain conditions when they're chronic, that can happen. So we're talking about central sensitization. And central sensitization is a phenomenon or a process that occurs in multiple pain states, such as neuropathic pain and inflammatory pain. When we talked about pain pathways, we were looking at that spinal central synapse, but there's also a synapse that's involved in the facial nerves and in the nerves in the meninges, and that's for the trigeminal nerve. And so again, you're just going to have a synapse that looks exactly like that central spinal synapse, but here's going to be the trigeminal nerve. And we can get sensitization at that synapse, just the same thing, except for now that's going to create a chronic pain state with chronic migraine, where that synapse is now extra sensitive. So let's go through that normal spinal central synapse, and then I'll show you what happens when we have sensitization to it. So normally we had that primary pain afferent came in, or nociceptive afferent. We had an action potential. We opened up voltage-gated calcium channel, released neurotransmitters in that central synapse. That was glutamate, it was CGRP, and substance P. We remembered that normally we had magnesium blocking that NMDA channel. So when we first had an action potential and release here, we're going to depolarize, maybe get a action potential. That's fine, get a little signaling, pain signaling there. But we're not bringing that NMDA receptor on board yet. Once you've fired several times and gotten the glutamate and TRPV1 receptors activated several times, now you're going to have it highly depolarized inside that cell. And now your magnesium's going to pop back off. And now it's open for that to let calcium in. So that's what it looked like in a normal transmission. So I just dropped a bottle of Pepsi on my foot and it hurt. I got this normal transmission through there. When it becomes sensitized, when we get this central sensitization, which was a form of LTP, we're going to get synaptic changes, and those are going to increase transmission of the signals through that pain pathway. So the reason that you get the onset of these synaptic changes is because of the high firing. So when you get multiple action potentials coming in very quickly over a long period of time, now you're releasing a lot more glutamate, a lot more CGRP, a lot more substance P than you had before. Now you've gotten more and more and more activation. The AMPA glutamate channels, the TRPV1 channels are depolarizing the cell. the AMPA channels are depolarizing the cell, and we're going to be getting action potentials. But now that we're having over and over, we're getting more and more activation of those AMPA receptors, more and more of the TRPV1 receptors, and that NMDA receptor now is exposed to this much more positive cellular environment, and the magnesium that it had blocking the receptor now pops out. So you lose that magnesium block, and now that NMDA receptor can let calcium in. And calcium is a really important intracellular messenger. So when that calcium comes in, it's going to now start gene transcription. It's going to change the way that kinases are phosphorylating receptors and other proteins. And now you have this huge change on the inside of this postsynaptic cell as a result of this barrage of nerve firing. So I cleaned that up a little bit so that you could see what's going on inside this cell. And so we had that huge amount of calcium come in, and we're going to see the result of upregulation of different genes and different kinases. One of the things that's going to happen is that we're actually going to put in more AMPA receptors and NMDA receptors. So I'm sorry, this is looking really bad. Let's put a few more AMPA receptors here. And so now you've added more receptors. The next time that neuron fires, it's going to have more receptors able to be activated. So even if now it goes back to firing the previous normal amount, there's more postsynaptic glutamate receptors. One of the things the cells do is they put up more voltage-gated calcium channels. So that's yet another way to bring in more positive charge and more calcium specifically, which is going to trigger release of more neurotransmitter. So now we've seen changes that increase release. We have changes that increase response. And if we want to make things even crazier, all of this release of CGRP and substance P that had occurred at this synapse can sometimes even bring in and activate glial cells, which can now release some more inflammatory mediators, which, as we know, that inflammation is going to even further sensitize those cells. So let's go back and see that big picture. We had a primary injury that caused that peripheral primary nociceptor to start firing like crazy. So it was that primary nociceptor cell body comes into that synapse, central spinal synapse. And normally there's some stimulus here, noxious stimulus. You fire an action potential, everything's fine. You release, get an action potential in response, no problem. Something hurt just a little bit. But now that you have all these changes to this synapse, both pre and postsynaptically, all it takes is for that single action potential to come, and now you're releasing more and you're responding even more. So now you're going to get much more response. So what exactly are we looking at? We're looking at that glutamate overactivation, unlocking that NMDA receptor, which causes upregulation of more AMPA receptors and more NMDA receptors and other genes. And that is a calcium-mediated upregulation. Anything that's an NMDA receptor effect is going to be through calcium. We also saw upregulation of presynaptic voltage-gated calcium channels. We're going to see effects through the CGRP and substance P receptors, which you don't need to know specifically what those are doing, but those are also having internal cell effects. And you can get recruitment of glia, which increase the inflammatory signaling. So there's a whole field on this, researching these, and that's just a few of the things that are happening. But that idea that multiple action potentials, strong pain signaling is going to create these changes in the synapse is really important, because when we go back to that idea of when someone gets hurt and they're told, oh, just suck it up, ignore it, don't be a wuss. If it's really strong, severe pain, ignoring it and not treating it can lead to this central sensitization and can lead to a chronic pain condition that could have been avoided with appropriate pain treatment. So for central sensitization, and I have the word spinal in here to kind of remember that's what we're talking about in that spinal synapse. But again, that can occur in the trigeminal synapse or with migraines, so that's not the only place that can happen. But this central sensitization is occurring because of strong unrelieved pain. and it is going to create a long-term hypersensitivity to pain. And you often see it in neuropathic pain and chronic inflammatory pain conditions, secondarily to those initial injuries. So in neuropathic pain, you can have the nerve injury, which then becomes that neuropathic pain with those changes. But it also has this central sensitization as a second component to it. Same thing with chronic inflammatory pain. You have the injury that causes inflammation. If that inflammation doesn't go away, then you have that chronic inflammatory component creating pain, but then also that pain causing central sensitization. So central sensitization is not a form of pain. But it is a component of some types of pain. We see that patients with strong pain can develop lifelong chronic pain conditions. So if you're looking at treating central spinal sensitization, say someone already has it, what kinds of drugs could you use? Let's take a look. That's Synapse. What were the problems? We had increased calcium channels. We had increased NMDA receptors. They were increased, but they were also causing the problem quite a bit. We had increased AMPA receptors. So what was really important to this synapse really was that NMDA pathway, was activating those NMDA receptors. If we could get those NMDA receptors down, turn them off, we could start to let everything come back to normal. So one of the treatments for central sensitization are NMDA antagonists. And we have, as antagonists, we have ketamine, we have memantine, which was, if you remember, Namenda for Alzheimer's disease, dextromethorphan, and methadone. Methadone is an opiate, but it also has reasonable NMDA antagonism and is actually one of the reasons that it seems to be better for some chronic pain than some other opioids are. Another target here is going to be that voltage-gated calcium channel. We can look at voltage-gated calcium channel blockers, such as pregabalin.